help us. Doctors can't. This is what you need. Which and you don't need rehab. You don't need that medication you're on, which is really dangerous. When somebody with 20 years sober, whatever, is sitting in an AA meeting telling newcomers they don't need to be on medications and stuff. And I hear this all the time. And then the kid goes home and goes off of his psych med, and they find him hanging in his closet a couple days later. So there's that. But when they say doctors can't help us, Dr. Silkworth is the one who gave us step one. He's the one who told us what our problem was. He's the one who told us, hey, you suffer from an allergy to alcohol, a physical allergy to alcohol when you ingest it, and an obsession of the mind. It's both mind and body. Dr. Silkworth is the one who told us what is wrong with us. He wasn't an alcoholic. He was a doctor. The solution that we need, step two, a spiritual solution to overcome alcoholism, was given to us by Dr. Carl Jung, and he was not an alcoholic. He was a doctor. Without those two doctors, we wouldn't even be here. So it's really important what he says there. PTSD, bipolar, obsessive compulsive disorder, borderline personality, whatever it is, schizoaffective, that stuff. AA is not fixing that. That's not going to fix that. But what it'll do is it'll get you in the state of mind and get you sober so you can take care of that stuff and go see a doctor and have it fixed, because none of that stuff can be touched until you're sober. You can't go to a doctor. How many times I went to a doctor and they prescribed me with anxiety disorder, but I didn't tell them I was smoking crack, 2 days or a day ago, and I'm still high. I mean, it's none of that stuff can be touched until you're sober, man.
To your point, it drives me crazy because I've sat in meetings just like you.
Yeah.
And I've literally watched a guy with 30 years tell a guy that if he was on
those guys.
His antidepressant, I forget exactly which one it was, but it was an SSRI, that he was not sober. Yeah. And this kid came off of his meds and went off the deep end. Mm-hmm. Like, just because we're uniquely qualified as alcoholics and addicts to help another alcoholic and addict does not make us doctors, does not qualify us for mental health situations. It's asinine, the things that I hear in meetings sometimes. And everyone knows I'm a huge advocate for Alcoholics Anonymous. However, some of the people that come into Alcoholics Anonymous say some nonsense.
Well, I mean, how many times do you hear this? And it doesn't qualify us for a lot of things, man. I mean, how many times, people start sponsoring, they go on, and all of a sudden they consider themselves relationship advisors, spiritual advisors, financial advisors. I don't know a group of people that can screw that stuff up worse than the alcoholic and the drug addict. But here we are telling people when I talk from that book, and that's why that book's so important to me, because I talk from that book. Not all the rest of the stuff I don't have an opinion on, man.
Yeah, but I get gaslit too from my side of things. Like even last week, I've had someone tell me, "You're useless to me," and I'm like, "Thank you. Why am I useless to you?" And they're like, "Because you can't help me. I'm an alcoholic." Okay, so explain more about that. Like I know that you're angry that you're here and you're angry about your situation, but you telling me that I can't help you because I'm a physician or I'm a normie, to me, like any other person would probably upset or personalize that, but I understand where that person's coming from. So I don't get taken aback and I don't get upset. I just try to pull out of them, what do you mean by that statement? Because that's a loaded statement. And maybe you don't believe that you need me, but I'm sure I could pull something out of you that I could definitely help you with. And I'm not saying that it's a medication, and I'm not saying that you have to take medication. I'm just saying that I've been doing this and I've been working in the field, and I'm sure there's something that I can help you with, whether it's mental or physical or medication related.
Absolutely.
But I have heard that a lot. I do have patients come to me more in the outpatient setting after they get through like detox and residential, where they'll say, "Hey, I went to a meeting last night and I was told that, doctors just throw medications at us, in the initial stages. And I just need to know from you, is this something that I have to be on for the rest of my life?" Right. Or they'll say, "I spoke to my parent or my spouse about this situation and they agree with every angle."
So, and to me, what that is how about, let's get you sober. You get sober and you start taking some responsibility for yourself and you start becoming your own advocate. And you know how many people have no idea why they're on the medication they're on? We get clients in here all the time. They no idea. Well, why are you taking that? What's wrong? Well, what dosage are you on? Oh, no. Why don't you know?
What's the rule of thumb? You got to be working with somebody for 6 months to do a proper diagnosis when it comes to mental health.
Traditionally, what we're taught through the process is that someone has to be at least 6 months sober before you can formally diagnose them with a mental health disorder, such as major depressive disorder or generalized anxiety disorder, if it's a new diagnosis. Mind you, some people are diagnosed early on in life, in their teens, maybe early 20s, and they have a diagnosis coming in. That's a little different. But people who've basically gone untreated because they haven't seen a doctor or sought help, they've just been using, they then get into treatment. And everyone will say, I have anxiety, I have
Right.
depression, but I don't think people understand really what that means when they say these words, right? There's criteria that are utilized for these diagnoses, and I don't think people understand it. It's just thrown, these terms, anxiety and depression or ADHD, are just thrown around way too often, and people get labeled
Right.
way too often.
I think that has a lot to do with too with just to call it what it is, the recidivism rate of clients going to treatment. You know, you do get clients who have been to treatment over a dozen times. They pick up on these buzzwords,
Mhm.
these diagnosis codes, etc., and they think that they know what they mean, kind of to your point, and they go around diagnosing all their all their friends that they're sharing a room with,
Exactly.
and
Comparing meds.
exactly,
They
and
do,
it's
but they do that. It's
Yeah.
an honest thing, and then
Yeah.
I'll get their friends that'll come back the next day and be like, "So I think I have this. Can you prescribe me X, Y, and Z?" And that's a whole nother conversation. I don't laugh. Like, I appreciate that they at least are trying to kind of advocate for themselves and understand where they're coming from mentally and emotionally. But a lot of the times substances do cause overlap of symptoms, so we
Yeah.
really have to tease out. I agree with what you said.
Yeah.
You really have to tease out. You have to get the brain clean and sober and
Right.
free, even of medications that can be abused, or maybe they're even abusing prescription meds. Like, you have to get their mind free and
You have to
clear.
get them to a baseline, right? Like, how many times do
Exactly.
you see a patient come to us from another facility, and at that facility they were diagnosed with something and put on a medication? When they told me, "What, were you ever diagnosed with that before?" Well, no. So you're how many days sober? Are you 30? Okay, well, you're getting diagnosed with something that you're going to be labeled with the rest of your life.
But that also comes with a culture of, when you stop doing drugs or you stop drinking, patients, they want something to feel a certain way,
Mhm.
whatever that means to them, right? So they go to the nursing station and they want that clonidine or that Seroquel or that Visceral because they're having an emotion or a feeling and they don't want to feel it, or they don't like feeling it, or they don't even know what they're feeling because they haven't felt like that in 10 years. So they get into this habit now of building bad habits initially in recovery, of taking these, what we label comfort medications early on in treatment, to kind of numb those emotions, which is not a good thing either. So they need people like their therapists, like, patient care advocates, things like that, people like you guys, to talk them off that ledge, because in essence now they're getting used to taking a medication every 4 hours, and they don't
Mhm.
may not even need that medication.
Right.
It's just that process and that habit of taking something and putting something in their mouth,
Right.
and that then develops another bad habit.
I like that you brought up the term comfort meds. I don't know that we've ever really talked about that, but just so like our listeners know what that is. For instance, I go into detox, I'm coming off of opiates. There's some absolute discomfort and symptoms that come with that, being anxiety, restless legs,
Muscle aches and
muscle
pains,
aches and
like the
pains.
flu,
Yeah.
however you want to describe having the flu, hot sweats, fevers, chills, restlessness, can't sit still, insomnia, um, anxiety, racing thoughts, uncomfortable in their skin, irritable, angry, you name it, these are the emotions they're having.
So essentially, the way that I see it as the addict is like those were the meds in detox that took the edge off just enough for me to make it through detox. It was still
Right.
uncomfortable, don't get me wrong, But I wanted to ask you when you said that, is there a point in time, like when do you start evaluating as a doctor, like when these comfort meds need to be discontinued? Because one of the things that I see often, and it's not here at our facility, but I see people that go on comfort meds in detox and stay on them indefinitely,
Yeah.
and also even see them get doses increased. And I'm like, what's going on here?
And that's a double-edged sword, but that goes back to they got into the habit of taking a medication to help ease their comfort, but what is their comfort for? Is it because that emotion that they're feeling? There is that thing of post-acute withdrawal symptoms where yes, you go through the detox phase, which is usually 7 to 10 days, where you really need those medications just to keep the patient in-house, to keep them safe from themselves, obviously. But after that time, you have these protracted withdrawal symptoms, which are prolonged withdrawal symptoms. And depending on the substance that it is, it can be weeks, sometimes months. So these patients will stay on certain meds longer probably than needed, because when I meet them at that in the outpatient setting, that 30, 60, 90-day mark, I am in tune with that. Every time I meet them, I see their list of 10 meds. I'm like, are you taking this medication? Same thing you kind of said.
Mhm.
Why are you taking this medication? Do you know why you're on it? Do you know the dose? Do you know the name of it? Do you know how it's even helping you
Right,
at this point
right.
in your recovery? I go through each med one by one, and some of them are like, wow, you're right. No, I don't need that. And we slowly chop off that
Right.
list. I'm not asking them to stop it abruptly all at once. It's a slow little phase out. But I often get met with resistance. No, I need that medication.
I see that
So,
with, for instance, like Seroquel a lot, where let me ask you this. You're the medical professional. I imagine that there's probably, just because, for instance, Seroquel, it's an antipsychotic, but oftentimes in treatment it's used as a comfort med for sleep and maybe what else? Just sleep,
Anxiety,
anxiety.
mood.
I see it mostly
Just
for sleep, I think, more than anything.
just because it's non-narcotic doesn't necessarily mean you're not going to have like a withdrawal symptom even from that, right? Like if you take Seroquel long enough, there's going to be some sort of negative adverse effect coming off of it, right?
Right. There's no type of documented like physiological withdrawal, for instance, like coming off of an opiate. But if you take something habitually enough, when you take it away from your body is going to crave it or need it. So if you're taking it for sleep and you abruptly stop it after 3 to 4 months, you may get this rebound inability to sleep, irritability, fatigue, lethargy. And that's what I try to explain to people, is that just because it's prescribed to you, you have to understand what you're taking and why, and the repercussions of coming off of it in the long run.
So I want to swing this around and look at this for a minute from the mind of the alcoholic and the addict. And this is why I loved when you listened to me do the big book study the first time, you said one of the great things about doing that for a doctor to hear me break that down, or a parent, is they get a
We never hit
snapshot.
record.